في شيفيلد، اتدرب على الاستاذ دكتور عبد النحاس، وحاليا بيشغل منصب consultant nephrology at the Shire Teaching Hospital in UK. وهيتكلم النهارده عن موضوع في غايه الاهميه اللي هو البري-dialysis care optimization وكومبلمنتاريتي مالتي ابروش. هيتكلم عن الكلام ده. اتفضل يا فندم. يعني انا بس اناونسمنت بسيط في شيء محتاج كده اللي عاوز يشرب شويه ولا حاجه نروحها كده وننزل ونرجع مكانه تاني مش مشكله.
Good afternoon, everybody. As Dr. Shaikh and Dr. Bakr invited me again to Mansoura. I'm very pleased to be with you here. My talk today will be optimizing pre-dialysis care. And I can tell you straight away that this slide is wrong. It's wrong because we don't know if every patient CKD, chronic disease, will end on dialysis. They might die before reaching that stage, and they might choose not to have dialysis. It's their choice with the advice and education. It was very interesting to hear the discussion of the first and second group, so I hope some of the questions or the concern raised could be answered or discussed here as well. So basically, let's define what's advanced kidney disease. I hope you know the stages of kidney a few years about chronic kidney disease in 5 stages. Actually, one of the stages is divided even further to 3A and B. And the single reason why they've done that, they don't just need more work, it's just to classify the patient according to the cardiovascular risk. The talk today will be focusing on stage 5, which is end stage renal disease, GFR less than 15 mL per minute, patients not yet on dialysis or any form of renal replacement, transplant or any other form. So basically they are the stage 5, not yet on dialysis. But I have to tell you they are a minority. Looking at the data from the States, this is about 19 million Americans with chronic kidney disease. And chronic kidney disease stage 5 is only 0.2% of the whole CKD cohort. But the majority is actually in stage 3, as you can see. And I hope you know that information before as well. It's 4.3% CKD stage 3. So why CKD 5 is important when it's only 0.2%? And the reason is because the cardiovascular risk is very high. Out of 100 CKD stage 5 patients, 36 will get cardiovascular events, whether that's an cardiac infarction or still whatever, but it's an event including myocardial infarction. And they die more, so they have the highest death rate as well, particularly stage 5. So that's why we're concerned about them, although they are minority within the CKD, but they have very high cardiovascular risk, and they need attention. So how to optimize their care of the advanced chronic kidney disease stage 5? Basically, a few points to discuss, and it will be more about. The main things are to refer them early to the renal service, renal clinics, and preferably with an identified renal clinic that runs in a multidisciplinary approach. When I say multidisciplinary approach, means that just more than one member of the team, like a nephrologist, specialist nurse, dealing with different aspects of the chronic kidney disease. We'll discuss that at a later stage. Educate patients, giving them options to choose from, to choose what they will be facing in the future, and clinically manage the condition and its complication, which is stage 5. And prepare them again for the future by either renal replacement therapy or conservative management. So refer to the renal service. I like cases because hopefully that will give you a wake up as well. So these are real cases from my clinic. Very similar. 2 patients, 50 years old, both of them. 20 years history of diabetes and hypertension. Both had stage 3, CKD stage 3, 7 years ago. But Mr. A refused the help of his GP, the general practitioner in the UK, and he refused to be referred to the renal service on few occasions. That was his choice. So he had a poorly controlled diabetes, poorly controlled hypertension, and he's non-compliant in general, doesn't take the medication, all of that. So, and finally, he was forced by symptoms to attend the clinic in January of this year with GFR of 8 mL per minute. He was in a miserable state, I can tell you, and he started dialysis with a tunnel line, burning gas, as an inpatient. He had to be admitted because of unwell. So you're surprised that kind of patient still there in the UK, because the patient refused the help it was given, but it's still there. seen it this year. The same patient, same age, same history. He was known to me for 5 years with his CKD stage 3, and his GFR dropped slowly over time. And he in January, the same with GFR reached, he was there already in the clinic, so his GFR was low as 8, and he started dialysis at the same time with a functioning fistula which he had last year. He started dialysis as an outpatient. He came from his home, directly to the satellite unit, driving himself, had dialysis, already visited the unit a few times before, met all the stuff before, he knew what he's expected. He knew everything what he's going to have. It wasn't a shock at all to him. It was all smooth. I don't use Arabic in lectures, but this is just to make it more clear. The difference between the two types of sudden dialysis life, Hubut Aimun, like Tayara Nazma, Hubut Aimun, or Mr. A, Hubut Atrari. This is crash landing, as we say it, and this is just smooth landing. So he landed smoothly on dialysis. He knew everything he would be seeing and having. And he was starting with functional fistula. Finishes dialysis with home driving as well. So you can see how big difference, the same kind of things. Mr. A had infections, he had a private fistula, which failed, he's diabetic, and then he had a mild infection, what it is good, while Mr. B was still dialyzing happily. End of this last month, Mr. A unfortunately was admitted unwell with fluid overload because he almost come to dialysis with fluid overload and he died with MI, while Mr. B is still alive, happy dialyzed. So you can see very similar start, but different fate. And that's what we want to avoid by optimizing the care of the patient, because Mr. B had a better optimal care. Not because we didn't offer to Mr. A, but it was his choice not accepted. And it was surprising we knew that many years ago, since 1998, we knew that that patient would be referred late to the renal service, would likely to start dialysis acutely, which is we said the crash landing. While patient was referred early on, likely to start dialysis electively, in an elective fashion, or planned. We knew this data from a long time ago, but some patients still present the same way. I'll be honest with you, there are many studies which show the same result, comparing early referral and late referral to renal service. Many studies over the years. So I've just picked this meta-analysis of systematic review, relatively new. This one is not very new, 2007, and this is a systematic meta-analysis in the American Journal of Medicine. I think it's from the States, and they are comparing the late and versus the earlier and late referrals. But this is 22, it's a pool of 22 studies. Probably the definition of late and early referral studies are different, but they pool 22 studies with more than 12,000 patients in it, dialysis patients. And obviously, the early referral, if the patient was referred early in all these studies, had better survival, and also had less hospital stay compared to the late referral. From last year, there was a systematic review looking at the same thing, at the late versus early referral to dialysis patient, from pre-dialysis patient and late to renal service, and they found exactly the same finding. In addition, there was significance with the starting with, we knew from the data that referring early patient was likely to start dialysis with functioning fistula, while referring patient late were likely to start with temporary access, vascular access like early. So as I said, we know this data before. We know the advantage of referring the patients early to the renal service. They will have a better survival after starting renal replacement therapy for years to come. They are less frequently admitted to the hospital with short hospital stay if they referred early. They're likely to start electively, smooth landing rather than acutely. They're likely to start with a functioning permanent access fistula or peritoneal dialysis is another choice. And in fact, they're likely to have more peritoneal dialysis and more home-based therapy than hemodialysis, because they will have the time to discuss options. Late referral will be associated also with poor outcome predictors, like anemia, because of the underuse of erythropoietin. They didn't have a chance to use it, and hypoalbuminemia, malnutrition, they didn't have a chance to sit with the dietitian to check. So obviously, if you have more time, you'll use the time, but if you miss the chance, you'll miss it. So, dedicated non-clearance clinic. These are clinics dedicated for CKD5 basically. So patients need more attention. rather than a general nephrology clinic where you see everyone. Still, the two models in the UK, the general nephrology clinic where you have a mix of all CKD stages and the dedicated low clearance where you only have CKD 5 patients, to give them more attention, to discuss about things which might not be relevant to other patients, and we just give them more time. But also, more importantly, in a multidisciplinary team. So usually the clinic run, I used to have a slide which unfortunately is not here, but I show you how the clinic runs in terms of you have the nephrologist, you have the specialist nurses and different types of specialists, you have the anemia nurse, you have the hospital access nurse, you have the dietitian, you have the social workers, you have everything the patient might need. And they have the advanced kidney care nurse who will talk to them about education and address all the concerns. Because sometimes, quite often, the patient might not discuss things with one person and he decides to discuss it with another person, just like he forget or whatever the reason. So seeing more members of the team involved in their care, giving them more options and chances is better. So the names are different: advanced kidney care clinic, predialysis clinic, or low clearance clinic, but the idea is the same. And again, it's a multidisciplinary team. And again, there is evidence showing that the advantage of just dedicated clinic is independent by itself. Risk factor, not seeing it or seeing in a low clearance clinic will give the patient a better survival, if you like, better managing their condition, slowing the progression of the CKD and postpone the need for reinvestment surgery. I'll show you some evidence about that as well. And like with dialysis, collectively again, functioning fistula, and increase home-based therapy because of education. They would have treatment experience. So this data, I think from the States, and they actually compared a year survival after starting dialysis, 109,000 dialysis patients who had been seen in a nephrology clinic, dedicated pre-dialysis clinic, 3 months, more than 3 months, and less than 3 months. So just two groups, one less than 3 months and one more than 3 months, and the one who seen more than 3 months in the dedicated nephrology clinic had better survival a year after starting dialysis. And this data from Leicester in the UK, where they were looking at the aim of that study was to look at the predictors of starting dialysis electively versus acutely. Why patients would start dialysis acutely versus electively. And attendance as dedicated pre-dialysis clinic was one of the independent factors to predict that the patient was likely to start electively rather than acutely. So the same information. This was just CKD 5 patient 109. So we know the importance of the low clearance clinic, but I will tell you later what we do in the low clearance clinic or the advanced kidney care clinic. Educating the patient, giving them options, very important. And that's something simple. It doesn't need a lot of money or resources to do. You just need some bit of system, and you can adopt it in any center, anywhere. Because you can educate your patient by different methods. You can educate your patients through giving them leaflets, booklets, websites. You can use DVDs, CD with information on it that they can read if they are. Some nurses do home visits to educate the patient in their own environment. Some patients will learn more in their own environment, seeing their home, if they can do home dialysis, that's an option. And sometimes we invite them all together in an education day where they come and speak to each other. Sometimes CKD stage, different stages mixed together, speak together with their own experience and symptoms. Usually helps them as well. But you can make it very simple as one-to-one counseling. You can just sit with your patient and tell them what you're going to tell them. Simple things. You tell them why they have kidney failure in the first place, causes of kidney failure, what causes of acute. They might have suffered an acute kidney injury. They might get a kidney injury of chronic later on. So you can tell them about how to avoid that, what's the causes, why they had it in the first place. Tell them about the symptoms, what they might get in the future. So they expect it not as a shock, but they understand they might get that in the future. Tell them about different options of dialysis and different types of renal replacement therapy, whether that's hemodialysis, peritoneal dialysis. What about transplantation? Tell them about they can have a transplant. Explore they can have their life donors, relatives, friends, you can give them a kidney. So it's important. Complication of chronic kidney disease as well, what they would be expecting at later stage if they are earlier stage. Medication, what medication they likely will have, because we give you the medication in the kidney failure is quite special, and why they need them, and what medication to avoid. That's very important as well. So educating the patient is not a very, very difficult task. It's not very taxing. You can do it. You can use whatever I said. But education for educated patient is not just a luxury, it's important because it increases survival as well. Sure, to have a better survival, patient will educate, have better survival when patient is receiving education. They're likely as well to start out effectively rather than unplanned or acutely, as it says. They're likely to have a better mood, better well-being. It will enhance their mood and reduce the level of anxiety. Obviously, they are anxious people. Having that kind of diagnosis like chronic disease with all its implications, it's very, very shocking. It's not very bad news. So educating them how to get through that is really important. And then give them power, how to empower them to control the condition. You probably come across patients with diabetes, and the diabetic patient is an example of how you empower patients, how they control the disease. They know the insulin, they inject the insulin. At some stages, they've been diabetic for many years. They were even better, knowledgeable, more than doctors seeing them the first time in terms of how the disease affects them. Because every patient is different. So empowering the patient is very important. Also to improve the self-care, to maintain them in jobs, and affect their families and their social life, all of it. And there's evidence that this special education program increased survival of patients. So this is a study from Italy. 229 hemodialysis patients who grow up for the survival of 37 with 8 months, and they were compared, well, this older group, they found that the group who had a proper predialysis education program had a better survival than the patient who had just unstructured care. So both groups were saying it's not late referral thing. We're not comparing here between late referral and early referral. Comparing between patients known to the incidents, all of them, but some group of them had proper structured education programs compared to the one who just came to the clinic with no structured program, education program, and the one who had structured education did better in terms of they lived longer, basically. So it's important. And this study from Canada, 355 hemodialysis patients, they looked at the same, but this was more structured, more detailed psychoeducational intervention. So they look at all the aspects of psychology of the patient and all the anxiety, all the psychological problems associated with the chronic disease, and they found that the one who received that kind of program of education is better up to 20 years. Still, they're doing better than the one who received it before dialysis. So you can see how effective they are. So what we do in the advanced kidney care clinic, how we manage the clinical condition of these patients. Basically, every time they come to the clinic, we review the symptoms, ask them about the symptoms, urinary symptoms, basically if they are stage 5 and GFR or 10 or 11, and start asking them what symptoms, do you have any symptoms, are you well? Simple questions to ask. Symptoms of fluid overload. Before starting examining them, just symptoms of fluid overload, symptoms of complications. And then we look at how to stop the progression. It's never too late. Don't say, well, it's GFR of 10. We'll start out soon. No, it's never too late. You can always still think about how to stop the progression of the chronic disease. And it's basically by managing the risk factors that would progress them, like controlling the high blood pressure, the diabetes, the proteinuria, trying to maintain that less than half grams a day, and addressing, most importantly, all the time, addressing cardiovascular risk. I showed you early on that they have high cardiovascular risk, high cardiovascular events, and they would die, more of them would die. So addressing that is still important. Treatment of complications, what complications they will get, metabolic acidosis, sodium bicarbonate. It's not only to treat metabolic acidosis, but there's evidence from studies, not many, about 1 or 2 studies, one of them from Professor Yaqub from London, showed that giving sodium bicarbonate slows the progression of chronic kidney disease per se as an independent factor. Treating the anemia, the target is 10 to 12. How to achieve that? You measure the iron status, they might need iron first. Oral iron is not absorbed in CKD stage 5. It doesn't get absorbed. Don't give oral iron to CKD 5, please. It's intravenous iron. How that will kill them. That's if they need iron, because you have to check it first, and they might not need iron, they might already fill it. But if they need iron, please give it intravenously. As I said, you've got your target to achieve, not more, not below, and then mineral bone disease as well, the bone disease, which is one of the complications of CKD, regularly measuring the calcium, the phosphate, the blood hormone, and correct that if needed. If they're hypocalcemic, give calcium. If the blood hormone is high, give active vitamin D, because the kidney won't make it at that stage. So just simple things to check every clinic and treat. Medication review, see what they are taking, advise them to avoid nephrotoxic drugs, non-steroidal anti-inflammatory drugs are nephrotoxic, they will finish off their kidney. So some of them will be surprised still on it, so you have to advise that if you've not done that before. Review what other medication they take. Also, advise them about contrast media. If you're going with the cardiologist for any other scans, angio, whatever, explain to them that the contrast media in the scan they go for will probably affect the kidney, and they might put them on dialysis. They have to be aware of that, because you don't know what other physicians will do and give them, not aware of the condition. So they themselves should be aware. So nephrotoxic is not just non-steroidal, it's everything that you can think of. Any medication that is not given in the right dose according to the GFR will be nephrotoxic, because it will accumulate. So they should be aware that kidney failure patient, the GFR is low, they have to mine the dose, just as simple as that, mine the dose. Some of the medication doesn't matter, but some medication and antibiotics should be reduced when they are at that stage. Dietary advice, I'll tell you about that later, but it's important. So these are the things you do in the clinic when you see them at that stage. Just give you more attention about asking the symptoms, treating complications, dietary review. Not necessarily you do it yourself. If you got a dietitian in your center, she can do it or he can do it for you. But if you haven't, then you might have a touch on that as well. Vaccination, why is that important? So we vaccinate the CKD5, particularly CKD5, not before that stage, to hepatitis B and pneumococcal vaccine and the seasonal flu vaccine, because when they start dialysis, there's high risk of getting hepatitis B, not through the machine, but through the environment as well, dealing with blood. So it's better, and the guidelines in the UK is telling us we should vaccinate them at that stage. Because if you left it too late, the immune system will be more weak, and they might not respond to the vaccine. So it's better to make the chance of that at that stage and give it now so that they do respond to it. And surprisingly, we also vaccinate patients on peritoneal dialysis, and you can ask me why. Because they're not going through hemodialysis. Because the peritoneal dialysis patient can interchange between that modality and hemodialysis any time. The peritoneal dialysis might walk, might shift them, bring them back, they might have peritonitis, and they might go back to hemodialysis for pain, so it's better. And then if it's late, they won't respond. They won't form an immune antibody against hepatitis B. It's a chance to do it now. Why pneumococcal vaccine and flu vaccine season, every year you do it. Because, annually you do it every year. Because the immune system is also weak, and it's better to vaccinate them. Even if it's not the age for it, even younger patients with CKD at that stage, it's better to vaccinate them. Right, what advice else we gave them about the risk factors we talked about, controlling the diabetes. Better to monitor at home if they have a machine, that's the best, and they have power and control of the disease. They have a target, the HbA1c should be less than 7. Hypertension, better to monitor at home. You can get a machine at home and have a diary for your blood pressure reading. And they also have a control, advise them about using salt diet. Tell them the target, what they are should be achieving. CKD patients should be achieving 130/80. And if they are consuming more than half a gram per day, it should be even slightly less, 125/75. Again and again, avoid nephrotoxic drugs like non-steroidal anti-inflammatory drugs. Mind the doses when they get any drug. The contrast we talked about. General lifestyle things. If they are overweight, high BMI, advise them to reduce weight. They might need help with that with a dietitian or general practitioner. Definitely stop smoking. They already have a high cardiovascular risk, so you don't want to make it worse. They have to stop smoking. You just advise. Exercise if they have high BMI. Exercise in general is useful to predialysis, and last patient I showed you last year. Implication on their life, social life, their job, their family, their career, what they're going to do in the future. As I said, CKD diagnosis would be shocking to them, so supporting them, not just a medical thing. Think of them about them as a human being. They're just human. They have a family, children, they have a job to go to, they have a career. They are the beginning of their career, their life. So just see that touch of the social thing as well, and the human part of them. So we talked about the medication. Just one thing you can do, as I said, it's never too late. You can always try to stop progression. Although ACE inhibitors is known to reduce proteinuria at earlier stage, but we found that actually they are the opposite, or they're not that helpful, or they might not reduce proteinuria at a later stage. And this is a study from Sheffield, from Professor Ahmed group, and we stopped the ACE inhibitor in the low clearance clinic, and the GFR improved for most of these patients, 61% improved GFR, and that was sustained for a few years as well. So think about what else you can do to save the time. Addressing the cardiovascular risk, we said very high cardiovascular risk, but not just the traditional risk factor you think about, which everyone knows, hypertension, smoking, high BMI, all this you know, I'm sure you hopefully will do that. But also think about non-traditional risk factors for cardiovascular disease. Proteinuria itself, and anemia, which is corrected, high parathyroidism, which you control that when we have a parathyroidism, the calcium phosphate abnormality itself, and vitamin D deficiency. Surprisingly, they could be vitamin D deficient. So some of them you might do something about, some you can't, like the proteinuria, you might not be able to do something about it, but you should be just aware of non-traditional risk factors for cardiovascular disease. Dietary advice, as I said, if you had a dietitian and saying that would be a bonus, and then just roughly what you advise them, their caloric need, you should meet their caloric needs, you shouldn't be malnourished. You should be advised about renal diet, which is low potassium diet and low phosphate diet. If they're diabetic as well, this is an additional advice about diabetic diet. Low salt diet if they have hypertension, if they have high cholesterol, low cholesterol diet. If they have a high BMI, you should be advised to lose weight. And fluid restriction at a later stage, then we should advise them how to manage fluid restriction. It's hard. Have you tried, especially in a warm country like Asia, have you ever tried to drink 1 liter per day? It's hard. So there should be strategies toward that, and advice as well, because they might not count things which they think is not fluid, like whatever, glucose or whatever, but they should be advised how to fluid restrict themselves with a dialysis station or a pre-dialysis station at late stage. So CKD progression, the very common question. You would only be asked that question. When I will start dialysis, doctor? It's difficult to answer it. Very difficult. You only can use the history of the patient to tell you how they've done in the past, how they will do it.
Skip this slide because there is a lecture
about it. Okay, fair enough. And then the last point of optimizing the care is to prepare them for the future. As we said, prepare them for renal replacement therapy, or the patient might choose not to have dialysis. It's just their choice, and it could be should be respected that choice if they want dialysis. We advise them about what does it mean not to have dialysis, which is they will die, but it might be their choice. They have enough. So you still support them. Conservative management is doing everything we've said, apart from just dialysis. Treat their complication, treat the risk factors, treat the everything apart from offering dialysis. And they might be at the last stage of their life, supporting them through that end of life care, and that's a big subject by its own. Then the choices of dialysis. If they choose to have dialysis, would they want it at hospital or at home? Appreciate that sometimes it's not available or not suitable for the patient at home, but it should be all discussed and given that choice. Transplantation, if they have a live donor, friends and family that can give them a kidney, or in countries which have a disease list or the catastrophic list, it could be enrolled to that if they are suitable and fit. And then timely access, which is doing the access in the right time, so it's ready for them when they start renal replacement therapy. And again, that's difficult to predict because it's related to the prediction of progression. Only the history can tell you about it, but the advice is it's better to have the AV fistula within 6 to 12 months to give you a range rather than a date before starting dialysis so the fistula is functioning. It's not just creating the fistula and leave it, because some of the discussion we had earlier was about which role is it, the nephrologist or the surgeon. I think it's the team. So you create the fistula, and then you do what we call surveillance. Surveillance, which is keeping an eye on the fistula and how it develops. So the surgeon should see the patient after 4 to 6 weeks after the surgery and see how it goes. Some of the fistula die straight away, they don't function. And some of them develop very poorly. So someone needs to look at them. So it's not just the surgeon, but the physician as well, bringing them back to the pathologist, bringing them back to the no clearance clinic, they will look at it. Especially, hopefully, with the vascular access nurse, and usually the vascular access nurse is trained in hemodialysis. Because most of the nephrologists, most of you won't needle themselves. Most of you. And if you're not needling yourself, you can see the fistula as functioning, but in fact, needling it could be difficult, whether it's deep or not in a straight line. So in few occasions, you can think that the fistula is functioning, but actually on needling it, they have difficulty. So we're having as well the team, a member of the team who actually needle the fistula. It's not to do with the nurse doctor thing, but it's just someone who's been doing it. So I think both should be seeing the fistula and keeping an eye on it month after month and how it develops. Because if you created 6 months ago, 12 months ago, thinking, yeah, I've done my job, but it's not developing, then you've done nothing. The fistula should be ready. You have the luxury of time with the option of predialysis because you only need to do 6 weeks before for the healing and the training, so that should be enough. If it's slightly better, 8 weeks would be better, but you have more time. Last thing to mention about how often you see these patients. Well, I advise you to 65 patients you see every 1 to 6 weeks according to the need and the progression as well. But this is just there's no evidence base behind that, just an advice. So finally, to summarize, how to optimize your advanced chronic kidney disease care by early seeing your patient, prefer to renal service early on, having preferably dedicated low clearance clinic or advanced kidney care clinic in a multidisciplinary team, educating the patient, giving them options, empowering them, and managing their condition and its complications, and let them have some control over the disease and prepare them for the future. Thank you very much.
All of the sections today there are many issues you mentioned, like exercise, and exercise. I don't exercise twice a day. Machine lifestyle depends on the patient is very different. Original stress is there, the lancet paper and the ATP paper, lancet paper for the general population, they have physical activity is pandemic, leading to death or deterioration, one of the major causes of death, and one of the CQD, the HP labor, stress on the correlation between sitting and exercising. The more the sitting the person is, the more the likely of growth of progression of CQD. So it's a very important point. Second point, diet. Also, we have to invest by the way in the program, the training program, collaboration and coordination. They work together in cases and application on CQD and for dialysis. This is very important point.
Can I comment on point one? It's very good what you said earlier on. I think we are nephrologists, physicians, and we should lead by example. It's very difficult to advise your patient to stop smoking while your cigarette is there on the desk. So how you do that? I have one of my colleagues actually there. Well, that's probably a difficult thing. He has a high BMI, and he is walking up the recipient, one of the recipient, and he keeps asking the recipient, you have to lose weight, and he is actually himself has to lose weight. So you see how the patient, they are human, so advising them, not just not advise them, they have to if you can lead by example, that's a good point to start with.
Regarding planning the situation, how many of what percentage of patients who were subject to this and you found them unnecessary? So you follow them for 6 months or a year, or whatever, and find patients don't need dialysis.
All right, you mean unnecessary? It's quite variable actually. It's quite variable. There are some patients who still start dialysis with some functioning fistula, or they have low follow-up, and some patients who have the fistula for a couple of years without needing it. I think the rate of progression is important. And as I said, it's sometimes difficult to predict, especially for the patient who suffers with acute kidney injury for any reason, because of the chronic kidney disease, and their GFR drops for a period of time, and most of the thing that said, it will continue. And they improve after that, as I said, for any reason. And then it improves and stays as it is, so sometimes difficult. But we have still patients with the fistula for 2
As you know, the use of the sodium bicarbonate in correcting the is just controversial. Controversial.
In correcting the milk acidity.
Yes. Yeah. Because give the patient overload and give
Are you talking about dialysis or pre-dialysis?
No.
Are you talking about
pre-dialysis?
Right, okay.
Makes the patient overload, and we know this sodium content makes the uncontrolled blood pressure uncontrolled.
I disagree with that. Sorry, I disagree with that. It's not necessary. I think it's important to correct the folic acid. It's very important. I don't see all the patients who will have sodium bicarbonate will have hypertension and fluid overload. And there are things you can do with the fluid overload and the hypertension. You can give them antihypertensive, you can restrict the fluid, see how much. Some of the patients drinks gallons and gallons of water and fluids. So I don't see it myself that sodium bicarbonate will make them all fluid overload and hypertensive. There are only few of them that might, and you can do something about it.
But so in pre-age patients,
yeah.
4 or 5, he has high hypertension and overload.
No, all of them will have hypertension, so there will be hypertensive or no hypertensive.
And overload.
Yes.
Can you sodium bicarbonate?
If you, perhaps the question would be, if you already have someone who's hypertensive, already overloaded, and metabolic acidosis, would you start sodium bicarbonate of that scenario? Then you might treat those first, and then postpone the decision of sodium bicarbonate later on. So you must control the fluid overload first, and the hypertension, and then start sodium bicarbonate.
What's the reason in the weight based?
My question is regarding the proper stage of holding the ACE inhibitors or ARBs in this category of patients, and also the optimal antiproteinuric doses of different ARBs. I read in some texts that for losartan it's 100 milligram, for cancertan it is 16 milligram, and for irbesartan 900 milligram. This one question. Another one.
Can I answer that first?
Yes.
To answer because it's two parts of it. The answer is no for both of them. Basically, there isn't a time where you have to stop basically. There isn't evidence behind that. There's no randomized controlled studies done. All what we did was just in total study with just a few patients, but we showed that some of them improved. So basically, you have to use your clinical judgment. At that later stage, the message is the ACE inhibitor might not be as helpful as earlier stage, especially for the one who's still proteinuric on the ACE or ARB. So the ACE or ARB didn't help them, and the GFR is actually going down. They likely have sclerotic elderly patients. So you have to use your clinical judgment and see, well, this is elderly atherosclerosis. The GFR has been, well, it's going down, and the ACE or ARB didn't help. And it's already hit GFR 12. Let's stop it. Right? So there's no ideal time. The second part of your question, there's no optimal dose for the ACE and ARB. Well, the advice of general practice thing, which is not evidence-based again, is to try ACE first, the maximum dose, and see what the response will get. Some studies, but not very many, and actually there are other studies which oppose that. They added ARB as well, and titrate the dose according to blood pressure, the maximum tolerated dose.
So the response is a clinical judgment.
Yeah, it's clinical judgment.
Another point, you mentioned that hemoglobin A1C less than 7 is your target. Before, do you think that this one is not affected by the uremic environment, and some are using what is called the carbohydrated hemoglobin?
Yes, we use that now. We don't use the HAP1.
We use the carbohydrated.
Yeah, we don't use that anymore. But I know that you're still using it. So, yeah.
Thank you.
What the concentration of sodium bicarbonate?
What? Sorry?
What type of concentration?
What drug? I mean,
8.4. We have 1.2.
you're talking about IV or oral?
Oral. Yeah. Oral. IV.
I don't. With predialysis, I don't use IV. Use oral. Sodium bicarbonate, 500 milligrams. To start with 1 tablet twice a day. It depends on the bicarb how low. If you go bicarb of 18, 20, you can use 1 tablet twice a day. If it's 14, you can use 1 gram, 2,000 TDS. It depends. You titrate as well. Everything is titrated up to the maximum tolerated, those are the response, the clinical response.
There's a nice paper discussing this issue with some patients and how the status
Yeah. Which is the normal range we have. Yes.
I'm working in a pediatric hemodialysis unit in Champion University. The problem we are facing not pre-dialysis scale, but when we transfer the patient to adult unit, as we treat the patient as children in our hospital, but when we adult unit, they different treatment. I would like to ask my question is, do you have any experience in your hospital to deal with this patient, how to make them psychological and emotional able to transfer them as they have very problem to be in adult unit?
This is a very important point, very, very important. Because what you rightly said, we call it transition, the transition period. Transition from pediatric service to adult pediatric, adult nephrology service. And usually, or even in transplant, even not just general nephrology, but even in transplant. In some UK centers, there's a transitional clinic. It's called transitional clinic.
We are working now in hospital, but we don't have a model to pull it or something like this. It's a mature idea in our hospital.
Well, the model is simple, and obviously, it's a lot to say about. The simple frame is that the pediatrician who used to look after the patient or the child all the life will come to the clinic, the same setting as he used to see him before, with the other nephrology. So they are actually like handing over the care, but not just in one clinic, in few sessions until they feel that the adult now is well to receive the adult service. So they make sure that he's happy and everything went smoothly. It's very smooth rather than cash handling. But we found that the pediatrics who were adult and been referred to the adult service as a shock or abruptly the ward, they will have non-compliance, they might not come to the clinic, clinically will do worse.
Okay. And we need a psychologist and social worker.
Not necessarily. It depends if you need. Yes, they will be there to help. But some of them, the transition is very smooth. I think initially you need the pediatrician and the other nephrologist. Initially, yes.
Last question.
I asked about the element of NSA or even before NSA. This is high order. It is necessary to get every patient on the direct therapy.
Well, Sadar doesn't work below J. They work very poorly below J5 certain minutes. So it's not very effective as directly. But to answer your question, no. The answer is no. It's not everyone should be on direct. It depends. It depends on the fluid state. If they are fluid, you need to be directly. But some of the antihypertensives, to control the blood pressure, there are some studies show that the addition of small dose of diuretic with the antihypertensive will make it more effective to control the blood pressure and blood pressure. Yeah, exactly.
You should cut down small and
exactly.
My question is it offered to maintain even output with the to maintain a good even output?
You won't get them hypertensive. You shouldn't get them hypertensive. You just get it right. But if you get them hypertensive, they will have like an episode like acute injury on top of the chronic, and they will affect their residual function, go to far further. Yeah.
Thank you.